Welcome to this explainer on interpreting VEMP reports to really elevate your clinical vestibular rehab practice. Most vestibular reports out there cover the canals incredibly well, but they often leave the otoliths pretty poorly defined. Well, today we're fixing that. We're going to read VVEMP, oVEMP, and SVV results together and figure out exactly what each one adds to your exercise prescription. This explainer is based on the literature review, Vestibular Function Testing, Interpretation for Physiotherapists, published by Australian Dizziness Clinics. Available at australiandizzinessclinics.com. Okay, let's dive into a scenario I'm sure we've all faced. Imagine you've got a patient who just finished 6 weeks of highly targeted, canal-specific vestibular rehab. Their VHIT numbers, they might look great, but clinically, they are still dealing with a persistent head tilt and this stubborn, lingering later repulsion. So what's going on? Why do they just plateau? Section 1. The missing otolith piece. The missing piece to this whole clinical mystery is usually hiding on a VEMT report. A report, by the way, that most therapists never even request. If we look at the 3-vertex model, we've got canal function, otolith function, and central integration. Most of our therapy plans, they cover the canal and central vertices really well. But missing that otolith arm is literally the most common reason a rehab program stalls out when symptoms like lateral pulsion or head tilt stick around. Section 2. cVEMP, Saccular Function Assessment. All right, let's look at the first tool for testing otolith integrity, the cervical VEMP, or cVEMP. This test specifically measures how the inferior vestibular nerve and the saccule respond to a high-intensity auditory stimulus. It essentially gives us a direct, clear window into the structural integrity of that specific inferior routing. Now, when you actually get the report, you need to know exactly what to look for. The response for cVEMP is recorded straight from the ipsilateral sternocleidomastoid muscle, so the SCM on the exact same side as the stimulus. And the crucial numbers you want to scan for, those are the P13 and 23 latencies. So what's our clinical threshold here? Well, here is your hard clinical rule. An asymmetry ratio of over 35% equals saccular loss or hypofunction. And hey, if the response is absent altogether, that's obviously a massive red flag too. Translating all this data to the bedside, what does a patient with an abnormal cVEMP actually look like? Well, think of the saccula as the body's biological plumb line. If it's off, the patient tilts. It's that simple. Saccular dysfunction clinically presents as a head tilt, asymmetric otolith input, and just atypical balance overall. So if your patient shows these symptoms and their canals test perfectly fine, you are almost certainly looking at a saccular deficit. Section 3. oVEMP, Utricular Function Assessment. Now, moving right along the pathway, the ocular VEMP, or oVEMP, shifts our focus completely. This one tests the utricle and the superior vestibular nerve. Unlike the cVEMP, which measures the neck, the oVEMP response is picked up via the contralateral inferior oblique muscle. That means we're looking at the eye muscle on the completely opposite side of the stimulus. When you're reviewing this part of the report, keep your eyes peeled for the N10, P15 latencies. And guess what? The rule of thumb here remains remarkably consistent. Just like we saw with the cVEMP, an asymmetry ratio of over 35% on the oVEMP strongly indicates utricular loss or dysfunction. Clinically speaking, this is heavily linked to an ocular tilt reaction and that stubborn, persistent later repulsion. Let's do a quick comparison to really lock this into memory. The cVEMP travels down the inferior nerve to the ipsilateral neck, right? Meanwhile, the oVEMP routes up the superior nerve to the contralateral eye. Understanding this cross-routing is absolutely crucial for making sense of the raw data you're going to see on the testing sheet. Section 4. SVV, Subjective Visual Vertical. Now, what if you don't have immediate access to VEMP testing in your clinic? Don't worry. Subjective Visual Vertical, or SVV, is a fantastic high-value bedside alternative. SVV basically involves having the patient align a tilted rod to what they perceive as true vertical in a dark room. It perfectly complements the oVEMP by measuring utricular function, and the best part? It lets you track their weekly rehab recovery right there in the clinic. No expensive equipment required. The magic number you need to remember here is 2.5 degrees. A deviation of over 2.5 degrees from true vertical practically confirms utricular asymmetry. It is a brilliant, fast way to quantify exactly what your patient's brain is perceiving. Section 5. Translating data to rehab. So the big question, how does finding an abnormal VEMP or SVV actually change your exercise prescription? Why does it matter for your day-to-day practice? Well, the main takeaway is that an absent or highly asymmetrical response completely flips your patient's deficit profile. You're not treating a pure canal lesion anymore. You're now dealing with a mixed canal otolith lesion, and that requires a major shift in your clinical strategy. If you spot otolith involvement, doing standard gaze stabilization drills alone just isn't going to cut it anymore. You need to immediately introduce head tilt control exercises, do these both with and without visual references. On top of that, you absolutely must integrate dynamic head-on trunk balance work into their routine. This decision tree is a great visual for grounding that treatment pathway. Notice how the flow diverges? If you've got unilateral or bilateral canal loss, you head straight down the paths of VOR adaptation or substitution training. But if you see otolith asymmetry, it distinctly branches off into targeted otolith balance work, things like head tilt and dynamic activities. You always want to perfectly match the exercise to the specific structural deficit. I want you to remember this clinical pearl. If lateral pulsion or a head tilt just won't go away after you've thoroughly treated a canal lesion, requesting a VEMP and performing an SVV is your immediate next step. Don't just keep pushing VOR times 1 and 2 if the otoliths are the actual culprit here. In the fourth and final explainer of this series, we're going to bring it all together by integrating vestibular function testing into the rehab plan. We'll explore the 3-vertex map of canal, otolith, and central integration, plus case-based prescriptions that honestly just fall out mechanically once you know how to read the report well. So, ask yourself, are you missing the true cause of your patient's plateau by ignoring the otoliths? It might be time to start asking for that VEMP report. For more resources, literature review, clinical cheat sheet, audio overviews, and the rest of this series, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.